So, good morning, everyone. Myself is Dr. Harshit Agrawal. I'm an MBBS MS MCH from AIIMS New Delhi. I'm a trauma and acute care surgeon, presently located in Uttar Pradesh. And what I'm going to do is, uh, I will be dealing with some surgical emergencies and how to deal with it in a series of lectures. So in the coming series of lectures, what we will be dealing with number of cases of acute care surgery, be it acute intestinal obstruction, for example, appendicitis, the perforation peritonitis, cause traumatic emergencies in the form of liver trauma, splenic trauma, etc. And we will go about it and see what are the recent updates and advances in the management of these cases and how we can do and improve our practices for managing these emergencies. So today we will be dealing with acute intestinal obstruction. The objectives will remain to study the etiology and pathology of AIU, to study the clinical presentations of AIU, and to study the management of principles of AIU. Now remember one thing, that this all presentations will be focused on clinical examinations and the advancements in the recent updates in the management of these cases. So first of all, we all know that acute intestinal obstruction is a very common finding, a very common disease which we encounter, and it comprises 5% of all acute abdomen cases. The most common cause of AIU remains adhesions, followed by tuberculosis, followed by neoplasm. And about 80% of AIU gets resolved by NM. However, this is a Western data where adhesive obstruction is very common. In India too, adhesive obstruction is very common. But in India, what we can also note is that tubercular obstructions, neoplastic obstructions, these are also fairly common entities. The average hospital stay is about 8 days, and there is 3% in hospital mortality per episode. Remember, I'm not talking about per case, it is per episode. There is 3% in hospital mortality, which is recorded for intestinal obstruction. The causes of small bowel obstruction and the large bowel obstruction are differential. So in small bowel obstruction, adhesions remain the most common cause in 55 to 75% of the cases, subsequently followed by hernias and followed by malignancies. While in large bowel obstruction, we do not find adhesions as the cause of obstruction, which is very rare finding. But neoplasm is one of the most common finding while we are talking of large bowel obstruction, followed by volvulus and followed by diverticulitis. So if we see that there is a huge difference between the causes, adhesions in small bowel while malignancy in large bowel. Now, intestinal obstruction has been divided into following types. Based on duration, it is acute versus chronic. It might be a dynamic versus adynamic, or you can see, which we say as mechanical versus paralytic ileus. It can be a proximal versus distal obstruction. Where, for example, small bowel obstruction versus large bowel obstruction. So this is how they have been divided. Another type of division is additional versus non-additional division. But these are main three types of divisions which we refer. American Association for the Surgery of Trauma has actually given a grading system for bowel obstruction. Now, it divides intestinal obstruction into 4 grades, 1, 2, 3, and 4. And it has 4 criteria: clinical criteria, pathological criteria, imaging criteria, and operative criteria, which we will deal. These are simple criteria to remember, but we will be able to deal it in much easier way at the end of the lecture when we are very clear about all these following findings. Now, coming to the pathophysiology of AIO. Now, what happens in AIO is that due to obstruction, there is distension proximal to obstruction. Now, why there is distension? Because of air and fluid. We all know there is air fluid level. Fluid because of various digestive juices. Air or gas, it is because of both anaerobic growth. Now, initially, this gas consists mainly of oxygen and carbon dioxide. However, over the course of time, oxygen and carbon dioxide get absorbed, and eventually it is made primarily of nitrogen and hydrogen sulfide. Another point to be noted is that in case of bowel obstruction, bacterial overgrowth can be rapid. The bacterial overgrowth can be due to it can also lead to translocation of bacteria to the blood vessels. Now, it is to be noted is if mucosal barrier is breached, it may result in translocation of bacteria and toxin, resulting in bacteria and septicemia. Now, it is important to note that by breach of mucosal barrier does not mean that there has to be a perforation. There can be, micro breaches through which the bacteria translocates into the microcirculation, and then it can lead to bacteremia and septicemia. Another point to be noted that there is a decrease in the absorptive capacity because the bowel wall in the whole of the bowel length cannot be utilized, and there is increase in intraluminal secretion, which actually leads to dehydration in these patients. So you remember the old dictum that first of all, the patients are resuscitated. Obstruction, the patient comes with obstruction. You have to resuscitate the patient because he is highly dehydrated because there is loss of fluids in the intestine. Now, there are certain risk factors also which we need to keep in mind for additional obstruction. Now, apart from other causes of obstruction, additional obstruction, they are more common in open surgery and laparoscopic surgery. And we all know why is it so, because there is a larger raw area which is being created, the stitch line is larger, so there are higher chances of additional obstruction. In pelvic surgeries, for example, colorectal surgery and gynecological surgeries, there is extensive pelvic dissection which occurs, and there is high chances of additional obstruction. Age less than 60 years, this can be attributed to the fact that the younger generation lives for a longer period of time than the elderly population. So age less than 60 years may be, a confounding factor. Multiple laparotomies, we all are very clear with it. Again, a mental resection. I often have a tendency to resect the omentum, saying that, okay, just resect it, the omentum is very large, just resect it. But no, if you do mental resection, there are higher chances for additional obstruction. It is the policeman of the abdomen. Keep it as that. Penetrating abdominal trauma. Again, a very interesting finding. Not blunt abdominal trauma, it's a penetrating abdominal trauma, which actually is a cause for additional obstruction. Now, coming to the signs and symptoms of obstruction. Now, the first signs is acute abdominal pain. It is the first symptom, we all know. It is colicky in nature. But in later stages, when the bowel gets tired, fatigued, in that case, it becomes diffuse. It is usually centered around umbilicus. Next point to be noted is about vomiting. Vomiting, you have to note the character. Now, in an obstruction cases, you can find non-bilious, bilious, or fecal vomiting depending on the level of obstruction. A non-bilious vomiting you can encounter in gastric outlet obstruction, a bilious vomiting in small bowel obstruction, a fecal in a large bowel obstruction. You also need to understand the interval between onset of pain and the vomiting, because in large bowel obstruction, vomiting is often very delayed, while in small bowel obstruction, one of the earliest signs is vomiting. Next, you have to keep in mind the obstipation. So, for example, during the initial phases, patient may pass feces due to increased propulsive activity, but over a course of some few hours, there will be absence of passage of flatus or feces. But in the initial phases, patient may pass feces. Now, coming to the signs. Signs are very important. The shape of the abdomen, you need to see the symmetry or the asymmetrical shape. For example, you can see the bowel loops often being very well visualized on the abdomen in cases of intestinal obstruction. And you can also note peristaltic activity. Second thing, that's the shape of the abdomen in the form of protuberant, distended, or scaphoid. Again, all of these can occur in case of intestinal obstruction. In case of gastric outlet obstruction, you can have a scaphoid abdomen. You can have a distended abdomen in cases of large bowel obstruction. You can have a protuberant abdomen hiding a distended abdomen underneath it. So in obese patients, you have to be extra careful in asserting the shape of the abdomen, because you may say that this is only an obese patient having a protuberant abdomen, but he may hide a distended abdomen beneath. Next thing is about guarding. There can be guarding, localized, diffuse. Again, the tenderness, localized or diffuse tenderness. Localized tenderness is actually a sign of ischemia, while diffuse tenderness may occur in cases of perforation or extensive bowel ischemia. Next important thing is we often, our masters used to ask about bowel sounds in case of intestinal obstruction. And when in doubt, we used to say that the patient is having sluggish bowel sounds. This is one of the most idiotic answers we used to always give. So remember, bowel sounds is a very important thing. Why they are important? That in case of intestinal obstruction, they may be present, they may be absent, they may be exaggerated. And the absence of bowel sounds actually suggests that the patient might have landed up into peritonitis, while the presence of bowel sounds often suggests that the patient may not have had perforation, but he may have an obstruction. However, in delayed cases, there may be absence of bowel sounds without perforation as well when the bowel gets fatigued. Second thing is digital rectal examination. Again, in my PG days, when my master used to come for rounds after the emergency, he used to ask me about the detailed rectal examination obstruction patient. I used to say, why every time he's asking for that? This is a very important point. First of all, it helps you to differentiate between pseudo obstruction and mechanical obstruction. In a mechanical obstruction, what you find is a collapsed rectum, while in a pseudo obstruction, you find a ballooning of the rectum. Number one. Number second thing, you can also find impacted fecalith, especially in cases of elderly population where fecaliths are often a major cause of obstruction. Next, obviously, we need to examine the hernial orifices to look for any cause of obstruction there. Now we will go about these guidelines. These guidelines were published in 2011. Actually, these are very beautiful guidelines by World Society of Emergency Surgery. We will keep it in the back of our mind and we will go ahead discussing a few of the points here. Now, after signs and symptoms, there are three imaging modalities which we can offer for the patient for the abdominal X-ray, the ultrasonography, and the CCT antenna. Now, the question occurs, why do we want imaging modality in an obstruction case? Again, three questions. First of all, we need to identify whether there is actually obstruction or not. If there is an obstruction, then it is at what level? Number one. Number second thing, what is the cause of obstruction? And number three thing, third is it severe or complicated? So first of all, we need to ascertain whether there is actually obstruction, whether it's a small bowel, a large bowel, or gastric outlet obstruction. What is the cause of obstruction? Is it neoplastic? Is it adhesion? Is it because of tuberculosis, etc. And number third thing is it complicated with bowel ischemia or peritonitis? So we need to find answer for these three questions. Now this is a table discussing the advantages and disadvantages of the imaging modalities. If we see the plain abdominal X-ray, it has a disadvantage that does not give any etiological diagnosis, but it is easily available. However, in some cases, it actually gives you etiological diagnosis. For example, in case of volvulus, it will give you correct etiological diagnosis as well. Number second thing is computed tomography scan. Yes, it's a beautiful study. The only disadvantage remains ionizing radiation exposure and contrast nephropathy, but it's the best in diagnostic modality for obstruction. Endoscopy only for large bowel obstruction cases. For example, in case where you are planning a therapeutic management, only in those cases you go ahead for an endoscopy. But it is riskier, it can lead to perforations, etc. in patients with intestinal obstruction. These two modalities were actually utilized in the earlier stages, in the early era when patient used to undergo surgery for etiological treatment. It was a diagnostic imaging model, diagnostic often used as for diagnosis as well, surgery when there is a doubt, surgeon used to give for surgery. But since we are now very much equipped with most of the imaging modalities, it is really required as a diagnostic, but it is often still being used as diagnosis, confirming the diagnosis. Now, the first imaging modality is X-ray. Abdominal X-ray, the diagnostic accuracy is approximately 60 to 80%. What you need to see is dilated sloops of small bowel larger than 3 centimeters, multiple air fluid levels, greater than 2.5 centimeter in width. Another thing to be noted is paucity of the gas in the colon and the gastric distension. Now, these are the pictures. Now, these are two very important questions which is often asked in the exams, whether to go for an erect X-ray or whether to go for a supine X-ray. Now, Love and Bailey clearly writes that X-ray abdomen supine is to be done. Now, why it is to be done is that if you see the erect X-ray abdomen actually gives you a diagnosis of air fluid levels. However, a supine X-ray actually tells you that there are small bowel loops, what we can see is plica semilunaris or valvular comitendens. These are, these are small bowel loops that is getting dilated. And there is paucity of the gas in the colon. So there is chances there might be a small bowel obstruction. And again, if you see, this is a classic case of large bowel obstruction. This is, you can see the colon being massively dilated. And this is a case of large bowel obstruction, while this is a case of small bowel obstruction. So an X-ray abdomen supine actually provides you information about the level of obstruction, it gives you an indication that yes, this is an obstruction, and it also tells you the level, and you can think of, based on the level of obstruction, the pathology. You need to remember the rule of three, that is, the diameter of small bowel is less than 3 centimeters, while colon is less than 6 centimeters, and cecum it is less than 9 centimeters. So in an X-ray, if there is diameter of the bowel is larger than these values, then you suggest or you think that the patient might be having intestinal obstruction. Next modality of choice is ultrasonography. It is actually hugely operator dependent. Another thing to keep kept in the mind, it often does not gives you the cause of obstruction and the level of obstruction. So what you can see is that a fluid-filled small bowel loops dilated to more than 3 centimeters. Length of the segment should be more than 10 centimeter, and a to and fro peristaltic movement you can see in ultrasonography. Then it is known as, then you can label it as intestinal obstruction. But again, there are chances that you may not understand the correct level of obstruction. You may not find the main pathology of the obstruction. So this is a picture which is depicting this is a small bowel and it is dilated to more than 3 centimeters. Hence, this might be a case of intestinal obstruction. You can see intraluminal echoes as well. That suggests that there is a residual matter inside the small bowel. Now, this is one of the most controversial topics, the CT abdomen. We all agree that CT abdomen actually is the investigation of choice. But remember one thing, you should not go ahead and do an NCCT abdomen. NCCT abdomen is actually equivalent to an X-ray abdomen. So unless the patient is having, contrast, he's in a case of renal failure or he will not tolerate the contrast, you do not go ahead and do a NCCT abdomen. Now, CT abdomen, we all agree that you have to give an IV contrast, but the question remains whether to give an oral contrast or not. Remember, it's always a IV contrast CCT abdomen. Oral contrast, it actually becomes dilute in the setting of small bowel obstruction, and it does not usually reaches the transition point before the scan occurs. This is a very important point to note, that it might not reach the exact site of transition point, because it might take 7 hours, 8 hours, 9 hours, 10 hours to reach to this exact site of obstruction. And you might have taken the films much earlier than that. Number second thing, important point to notice, oral contrast actually obscure the evaluation of small bowel wall, limiting evaluation of bowel ischemia. So if you need to see the small bowel wall, the signs of bowel ischemia, then oral contrast actually obscures it. Even American College of Radiology recommends oral contrast not to be used if high-grade AIU is known or suspected, because it wastes resources, does not add to a diagnostic accuracy, and can lead to vomiting and aspiration. So oral contrast is not to be used unless there are specific indications. But the things get complicated with the introduction of gastrographin. Now, it is a gesture of sodium dihydrate and meglumine dihydroxide with an osmolarity of 1900 milliosmol per liter. Important thing is to notice it's a hypertonic solution. So it decreases edema of the bowel wall and enhances smooth bowel contractility. So it actually is being utilized as therapeutic agent in many of the cases. Now, was published in British Journal of Surgery in 2007, where it actually evaluates the role of water-soluble contrast agent, oral water-soluble contrast agent, and it says, although gastrographin does not reduce the need for operation, it appears to shorten the hospital stay for those who do not require surgery. So it's a very subtle and a very important point. It appears to shorten the hospital stay for those who do not require surgery. Very small, but a very important one. But things again get more complicated. In Scotland, a multicentric trial was done to evaluate the role of gastrographin, and this suggests that the gastrographin administration of no benefit in patients with adhesive small bowel obstruction. So they clear-cut ruled out everything that there is any use of gastrographin in cases of small bowel obstruction. But things again get complicated. In 2019, another paper was published in which they said that a significant proportion of small bowel obstructions actually require more than 48 hours to resolve after gastrographin. In initial studies, they used to wait for 24 hours after giving gastrographin, but they waited for more than 48 hours. So things still got complicated. So what I would suggest it that always go for an IV contrast initially. Do not go and give an oral contrast. Now, IV contrast, if you see that there is a case of adhesive obstruction and the patient's clinical features are not so bad, then you can give him a trial of gastrografin for 24 to 48 hours, see what the outcome is, and if it gets resolved, it's well and good. If not, you go ahead and do a surgery. Now, what are the CT findings of intestinal obstruction? These are dilated small bowel loose more than 2.5 centimeter up from outer wall to inner wall. There should be normal caliber or collapsed loop systole, or there can be small bowel feces sign. Now, what is small bowel feces sign? This is the presence of particulate feculent material mingled with gas bubbles in the lumen of the small intestine. Now, this is a very important and very important thing to notice. Particulate feculent material which are present into the small intestine. Another thing to be noted in while reading the CT is signs of ischemia. What are the signs of ischemia? There's reduced bowel wall enhancement. There can be bowel wall thickening. There can be mesenteric venous congestion. There can be free intraperitoneal fluid or mesenteric fluid. There can be situs. There can be unusual course of mesenteric vasculature. You need to keep these points in mind because these are important signs of bowel ischemia. And it separates complicated versus non-complicated. Now, management of the acute intestinal obstruction. There are initial management. We all know that you have to correct the ABCD of the patient, manage the airway, manage the breathing part, give him IV fluids, correct electrolyte abnormality, insert nasogastric tube, Foley's insertion, IV antibiotics, hematological and biochemistry screening, ABG analysis for acidosis, pH, and lactate levels you need to see, and you go ahead and do a radiology. Now, the further management is again tricky, and it depends on three important questions. Whether you can wait in the case of obstruction, NOM versus operative, whether you have to go for time, what is the timing of the surgery, and what about open versus laparoscopic surgery. So, NOM versus operative, if you see, you can try non-operative management in cases where there are no signs of complicated AIO and if there is partial AI. But in cases of complete acute intestinal obstruction, you never go ahead and do a NOM. Now, this study was done to find out the predictors for non-operative management in small bowel obstruction. And what they found that these actually are the predictors in which you cannot wait for non-operative management. For example, if the patient is having mesenteric edema, if there is extensive free intraperitoneal fluid, if there is some history of vomiting, or if there is severe pain, VAS score more than 4, or if there is non-enhancement of bowel wall and CT. So, if there are any signs of complicated intestinal obstruction, you need not to wait for non-operative management. You directly go ahead and do an operative management. This again was published in 2022, and it was a new procalcitonin based algorithm which they have set uh, uh, that if the procalcitonin level is more than 0.6, you go ahead and do a surgical management. If it is 0.2, you can go ahead and do a conservative management. But all said and done, they also said that in case of discordance between PCT values and clinical examination, management based on clinical examination is always prioritized. So whatever be the imaging, whatever be the biochemical, whatever be the hematological studies, if the patient's clinical examination reveals that he requires a laparotomy, go ahead and do a laparotomy. Do not wait for that. Now, what else to be done in NOM apart from the initial management? You can give a gastrografin trial. You can also give lactobacillus enzymaticon. But remember, you need not to wait for more than 72 hours while doing the non-operative management. Because after 72 hours, the failure rates are very high and the outcome actually becomes bad for patients who were being managed non-operatively. So do not wait for more than 72 hours. Now, this is an interesting narrative review. I think we should all read it because it's a beautifully written review of on bowel obstruction. And this is the algorithm which they have suggested that after doing the initial assessment, you check for the patient if there is abdominal wall hernia or not. If there is an abdominal hernia, you go and do an manual reduction. If yes, then you can go in and plan for an elective surgery. If there's no abdominal hernia, you again see for those three signs of obstruction. The three signs we wanted on imaging. Then you decide whether it's a small bowel or large bowel obstruction. If there is no ischemia or perforation, then you have to go and see if there's adhesions. As in small bowel obstruction, we can go for a conservative management. If there is neoplasm or internal herniation, you go for an emergency surgery. While in large bowel obstruction, if there is no ischemia or perforation, the people actually suggest colonoscopy, but often it is not required, because if there is a volvulus, you can always go for a derotation. But if there is a neoplasm, we often have to go and do a resection or a diversion colostomy in such cases. Stenting may not be that much effective, but you can give it a try, and CT will obviously tell you these findings of neoplasm, volvulus, and stenosis at present. Next question to be answered is whether to go for an open exploration or a laparoscopic exploration. Remember, laparoscopy is better, always better, but only in the hands of experienced surgeon. And ideal candidates for laparoscopic surgery are non-resolving partial AIO, chronic obstructive symptoms, proximal small bowel obstruction, anticipated single band, or no severe abdominal dissection. So all these cases are actually cases where there is not severe abdominal dissection, and you will be able to do a laparoscopic surgery by creating a new peritoneum. Contraindications to laparoscopy include an absolute contraindication in the form of hemodynamic instability, while there is a relative contraindication in the form of peritonitis. These are pictures of a band adhesion causing obstruction. This is a stricture which is present, leading to obstruction. Now, how to approach during laparoscopy? So remember, the first trocar should always away from the site of Olska. You can approach it to the Palmer's point or the Jan's point. You can go ahead and do a Hassan's approach. It's a viewable approach, and it is actually the safest approach in cases of intestinal obstruction. You can do next, you have to apply a combination of blunt and sharp dissection. You have to expose the collapsed bowel first, and adhesiolysis of only pathological adhesions is required. We always have a tendency to do adhesiolysis of all the adhesions, but it is not required. Only pathological adhesions need to be lysed. Next, how to prevent obstruction after laparotomy? This people have suggested adhesion barriers. So there are various adhesion barriers which have been proposed. For example, Sepra film, Interseed, Adapt, or spray gels in the forms of films, or sheets of these various materials. And there are also gels in the form of polyethylene glycol. So this is an example. This is about Sepra film. What is this? This is a transparent film attached to a paper. You apply it on the raw area, and then you remove the paper. So the film actually gets adherent to the raw area, and the bowel does not get directly in contact with the raw area, and it helps to prevent adhesion of the bowel wall with the raw area. Now, all said and done, we will again come to the AST scoring system. So AST scoring system, it divides a small bowel obstruction into 4 types. The first is the partial small bowel obstruction. Second is complete small bowel obstruction. Third is complete small bowel SBO with compromised but viable bowel wall. Now, bowel wall will be viable. Now, the fourth is if there is any complications with that. Now, clinical criteria in partial obstruction, patient may find class sound platters. There may be normal bowel sounds. There can be mild abdominal distension. In complete, there will be no flatus, but without generalized tenderness. In compromised bowel wall, you may find localized tenderness. While in cases of perforation or complicated, there may be features of peritonitis. Pathological criteria, we all know only when the patient gets explored, then we will be able to find the pathological criteria. Imaging criteria, the CT findings, again, in partial SBO, normal imaging, or you can find minimal distension. In complete SBO, there can be a transition point. In compromise but viable bowel wall, there can be evidence of complete obstruction and pending bowel compromise. In non-viable or in complicated, there is localized perforation or pre-air. In operative criteria, again, as was the findings of exploration. Last but not the least, about some points about tubercular obstruction. We need to avoid laparotomy as far as possible because there is high risk of fistula formation. The patient's history and CT findings which suggest a loss of weight, loss of appetite, malnourishment, mild to moderate ascites, abdominal cocoon, mesenteric lymphadenopathy, circumferential wall thickening, and a mental thickening. Now, why these are important is because you may always not find pathological or microbiological confirmation of tuberculosis, but the patient may be having features of tuberculosis. In such cases, empirical tubercle ATT can be given to these patients. So the take-home message remains: a diagnosis of AIU is made clinically and it is supplemented by imaging. The decision to operate versus NOM should be made early. Do not wait for more than 72 hours on NOM as well. Majority of adhesions of obstruction can be managed non-operatively. Water-soluble contrast can be given in patients with low-grade adhesive obstructions. You can go ahead and try. And laparoscopy can be attempted in AIU provided the surgeon has required expertise. Thank you very much. So this was my first presentation and I hope you will all like it. Comments and suggestions are welcome for improvement. Thank you, everyone.